Welcome to the Weekly Neurology Deep Dive, proudly produced by Amer Gavanini. Today, we're embarking on really a crucial journey, a deep dive into the features, outcomes, and treatment strategies for postanoxic status epilepticus following cardiac arrest. Our mission is to distill the most important actionable insights from a significant pooled analysis published in Neurology in 2025. And just a reminder, this deep dive is designed purely for educational purposes. It offers a summary of the research and has no commercial goals. We strongly recommend you read the full paper for all the comprehensive details.
Absolutely. And for those of you navigating, a busy clinical schedule and needing the essential takeaways right now, here's a practical summary of what this study reveals. First, a diagnosis of postanoxic definite or possible status epilepticus does not automatically doom a patient to a poor prognosis, especially when they present with fewer than 2 severe unfavorable prognostic indicators from the European Resuscitation Council, European Society of Intensive Care Medicine. Second, the electroencephalogram background before the onset of status epilepticus is absolutely critical for a good outcome. A continuous or discontinuous background is key. Remarkably, no patient with a suppressed or suppression burst background before status epilepticus onset achieved a good neurological recovery. Third, in definite status epilepticus, we observed that a higher discharge frequency, around 3 Hz, and pushing higher doses of antiseizure medications like levetiracetam and valproic acid, alongside guideline-recommended treatment, were associated with better outcomes. Fourth, the cessation of status epilepticus, whether definite or possible, consistently correlates with a good neurological outcome. And finally, early and continuous electroencephalogram monitoring isn't just helpful, it's, essential for optimal prognostication and effective management.
Okay, so with those critical insights in mind, let's unpack the data behind these revelations. Post-cardiac arrest status epilepticus has long been one of the most challenging conditions we face in neurology. Historically, it's been associated with incredibly high fatality rates, leading to this lingering debate. Are these electroencephalogram patterns a treatable condition, or are they simply an inescapable marker of irreversible brain damage? And this uncertainty has led to significant variation in how we approach these patients clinically.
Exactly. And that's precisely what this new analysis aimed to clarify. It's a powerful, multicenter, pooled analysis, combining individual patient data from the treatment of electroencephalographic status epilepticus. After cardiopulmonary resuscitation trial, the TELSTAR trial, with 2 local registries from Brussels and Geneva, this broad data set gives us a much clearer picture.
So who exactly were the patients included in this crucial analysis? What were the parameters that define this cohort?
Right. The researchers focused on comatose patients, specifically those with a Glasgow Coma Scale score of 8 or less, aged 18 years or older, who had been successfully resuscitated after cardiac arrest. A vital inclusion criterion was that their electroencephalograms showed a pattern meeting the American Clinical Neurophysiology Society criteria for either definite or possible status epilepticus within 72 hours following the cardiac event. Patients were excluded if their electroencephalogram only showed rhythmic or periodic discharges that didn't quite meet these rigorous criteria, or if their electroencephalogram data were simply unavailable.
And when looking at these patients, what was the ultimate yardstick for success in this study? How did they define a positive outcome?
Well, the primary outcome was measured by the cerebral performance category at 3 months post-event. This was then dichotomized into either a good recovery, meaning a cerebral performance category of 1 or 2, or a poor outcome, encompassing a cerebral performance category of 3 to 5.
Okay, let's look at the initial broad strokes then, the overall picture from the entire cohort. The study included, 274 patients? What did the demographics and general clinical characteristics of this group tell us?
Well, this was a significantly challenging patient population, as you might imagine. The median age was 66 years, with about 31% being female. The vast majority, about 89%, experienced an out-of-hospital cardiac arrest. About 52% presented with a shockable rhythm, and the primary cause of arrest was cardiac in about 69% of cases. The median time to return of spontaneous circulation was 20 minutes. And almost all patients, about 98%, received sedation during the first 24 hours.
Just about 9% achieving good recovery in the entire cohort. That's a number that really, it hits home for anyone working in the intensive care unit. It truly underscores how dire these situations often are, and why every piece of prognostic information is so desperately needed. What then, within this challenging landscape, began to emerge as factors that could perhaps offer a sliver of hope, or conversely, signal a definitively poor trajectory?
You're right, it's a sobering figure. However, the multivariate analysis did reveal some significant factors. A patient having 2 or more European Resuscitation Council European Society of Intensive Care Medicine criteria for unfavorable prognosis was strongly associated with a poor outcome. The p-value there was below zero point zero 0.01. Interestingly, status epilepticus presenting with motor features was also negatively associated with a good outcome. It showed an odds ratio of 0.49 and, again, a significant p-value. On the more optimistic side, the cessation of status epilepticus itself was significantly associated with a good outcome, with an odds ratio of 2.23 and a significant p-value.
Now, for many of us, the electroencephalogram is our crystal ball in these situations. What did the study uncover about electroencephalogram interpretation that truly shifts our perspective?
You hit the nail on the head there. This is perhaps the most profound takeaway. Our crystal ball now has a new critical filter. We found that not a single patient who achieved a good outcome had a highly malignant electroencephalogram background in the first 24 hours, nor did they have a suppressed or suppression burst background before the status epilepticus onset.
Before the status, okay.
It's a stark, almost black and white distinction. The background electroencephalogram appears to be the ultimate gatekeeper for recovery. In fact, all patients with a good outcome had either a continuous, which was about 75%, or a discontinuous, about 25%, electroencephalogram background before their status epilepticus. This clearly suggests that the underlying brain activity, as reflected in the background electroencephalogram, is a critical prognostic indicator.
That finding on the electroencephalogram background is truly powerful. The study then took an interesting turn, narrowing its focus. It excluded patients with 2 or more of those severe unfavorable European Resuscitation Council, European Society of Intensive Care Medicine prognostic criteria. What was the thinking behind this selection, and what new picture emerged in this more favorable group?
Right. The rationale was basically to remove patients whose severe brain injury indicators might have already predetermined a poor outcome, thereby isolating a subgroup where aggressive treatment could genuinely make a difference. This refined cohort comprised 94 patients, 52 with definite status epilepticus and 42 with possible status epilepticus. And what we saw was quite encouraging. In this more selected group, the rate of good outcomes significantly increased to about 25%.
25%, that's a substantially more hopeful figure. What specific variables began to correlate with these improved outcomes within this particular, more carefully chosen group?
So in this subgroup, a higher discharge frequency of electroencephalogram patterns was associated with a good outcome. The median frequency was 2.5 hertz for those with good outcomes compared to 2 hertz in the poor outcome group. That was a significant finding. What's even more striking is a dose response trend. Patients with good outcomes received significantly higher maximal daily doses of both levetiracetam and valproic acid. For levetiracetam, the median dose in the good outcome group was 3,000 milligrams versus 2,000 milligrams in the poor outcome group, a significant difference. Similarly, for valproic acid, it was a median of 4,400 milligrams versus 2,000 milligrams, also significant. And once again, status epilepticus cessation showed a strong association with good outcome, odds ratio of 3.92, significant p-value. However, when we looked at the multivariate analysis for this combined definite and possible status epilepticus subgroup, only status epilepticus cessation remained independently associated with a good outcome.
Okay, let's break this down even further. Within that selected group, focusing specifically on the 52 patients with definite status epilepticus, what unique insights did the data reveal there?
Right, for patients with definite status epilepticus, about 23% achieved a good outcome. Similar to the broader group, a higher electroencephalogram discharge frequency was associated with good outcome. Median of 3 hertz compared to 2 hertz, a significant finding. Crucially, receiving guideline-recommended status epilepticus treatment was also associated with a good outcome, which was significant. And, consistently, status epilepticus cessation was strongly linked to good outcome, a significant association there too.
So for definite status epilepticus, it truly appears that the treatment itself might be making a tangible difference in these selected patients. But how do we, disentangle that treatment effect from potentially just treating patients who already had a better chance? What's your take on that nuance?
That's a critical point to consider. And I mean, while it's an observational study, the consistent findings across multiple variables, including those higher doses of antiseizure medications like levetiracetam, where the median was 4,250 milligrams versus 2,000, and valproic acid at a median of 4,800 versus 2,000 milligrams, both significantly higher in the good outcome group, it suggests a robust association. It implies that for this specific group of definite status epilepticus who also lack the severe poor prognostic indicators, aggressive and guideline adherent treatment might be actively contributing to the improved outcomes. And again, no patient with a good outcome in this definite status epilepticus group had a suppressed or suppression burst background before the status epilepticus onset.
Okay, what about the other subgroup then, the 42 patients presenting with possible status epilepticus? Were there similar findings regarding treatment efficacy or prognostic indicators, or did the picture look different here?
Yeah, here's where the waters get a bit murkier for possible status epilepticus. About 29% of these patients still achieved a good outcome, which is interesting. However, the only factor significantly associated with a better outcome was the cessation of the possible status epilepticus itself. Unlike definite status epilepticus, we didn't see clear associations with guideline-recommended treatment, specific electroencephalogram features, or even higher doses of anti-seizure medications, leading to better outcomes in this particular subgroup.
That is intriguing.
It is, isn't it? It suggests that possible status epilepticus might be a more heterogeneous group, or perhaps it often represents a, self-resolving phenomenon where aggressive intervention isn't the primary driver of recovery. This really challenges us to think about when to push treatment and when to perhaps observe more closely for these possible cases. It's crucial to remember, though, similar to the other groups, no good outcome patient had a suppressed or suppression burst background before status epilepticus onset, even in this possible status epilepticus subgroup.
So, bringing all these threads together then, what does this pooled analysis mean for us as neurologists in our daily clinical practice, especially in those challenging moments in the intensive care unit?
Well, this deep dive truly highlights several critical paradigm shifts, I'd say.
Yeah.
First and foremost, definite or possible status epilepticus after cardiac arrest, particularly in the absence of two or more severe unfavorable European Resuscitation Council, European Society of Intensive Care Medicine prognostic criteria, absolutely does not preclude a good neurological outcome. The fact that about 25% of these carefully selected patients achieved a good recovery should inject a more optimistic outlook into our initial prognostication.
That's a truly significant and hopeful message to take away a more nuanced and potentially optimistic outlook than historical data might have suggested.
Absolutely. Another key message is the profound and frankly undeniable importance of the electroencephalogram background before the onset of status epilepticus. A return to a continuous or discontinuous background appears to be a necessary condition for a good outcome. This dramatically underscores the need for early and critically continuous electroencephalogram monitoring in all comatose cardiac arrest patients. It's not just a diagnostic tool, it's a vital prognostic one.
And regarding treatment, how does this study guide our hand when we're deciding how aggressively to intervene?
Right. Well, while status epilepticus cessation was consistently linked to good outcome across the board, the study presents a crucial nuance regarding treatment. For the overall group of definite and possible status epilepticus, guideline-recommended treatment wasn't directly associated with a good outcome in the multivariate analysis. However, in the definite status epilepticus subgroup, such treatment was associated with good outcome, especially when higher doses of levetiracetam and valproic acid were used. This suggests that for selected patients with definite postanoxic status epilepticus who lack severe, irreversible anoxic brain injury, aggressive and prolonged therapy might indeed be beneficial. For possible status epilepticus, the data suggests it might often be a self-resolving phenomenon, making the direct effects of treatment less clear-cut.
And as always, we must also acknowledge the inherent limitations that studies like this present.
Indeed. As an observational study, it cannot establish definitive cause and effect relationships. That's always the caveat. There's always the potential for allocation bias, where sicker patients might inadvertently have received different treatment intensities, or perhaps less aggressive care. Also, a small percentage of patients were not monitored with continuous electroencephalogram, meaning some early critical patterns might have been missed. And finally, while powerful, the subgroup analyses were based on smaller sample sizes, warranting careful interpretation. We need to be mindful of that.
Right. So as we wrap up this weekly neurology deep dive from Amara Gavanini, let's circle back to those practical summaries, reinforcing what you can take directly into your daily clinical work.
Okay, in summary, Postanoxic definite or possible status epilepticus is not uniformly associated with poor outcomes, especially if a patient presents with fewer than 2 unfavorable European Resuscitation Council European Society of Intensive Care Medicine criteria. The electroencephalogram background before status epilepticus onset is a critical predictor. A continuous or discontinuous pattern is required for good recovery, whereas suppressed or suppression burst backgrounds are uniformly associated with poor outcomes. For definite status epilepticus, aggressive guideline recommended treatment, including higher doses of antiseizure medications like levetiracetam and valproic acid, and achieving cessation of the status epilepticus strongly correlates with an improved prognosis. And finally, early and continuous electroencephalogram monitoring is paramount for accurate prognostication and timely, effective intervention.
This analysis truly gives us a more nuanced and in many ways more hopeful understanding of prognostication and treatment strategies for this challenging patient population. It really begs the provocative thought, doesn't it? Given the strong association of a more preserved electroencephalogram background and the cessation of definite status epilepticus with good outcomes, are we currently doing enough to actively treat and aggressively suppress these patterns in selected patients, particularly those who demonstrate a more viable background electroencephalogram?
That's the key question, isn't it? Further randomized controlled trials are certainly needed to establish definitive, ironclad treatment guidelines. But these data provide incredibly valuable insights to guide our current practice, empowering us to make more informed decisions at the bedside right now.
Thank you for joining us for this deep dive. Remember, this is a summary for educational purposes only, and we strongly encourage you to consult the full research paper for comprehensive details. We look forward to diving deeper with you next time.